Do you want to start speaking just so I can check the audio is working fine?
Can you hear me okay?
Yeah, I can hear you great. That's perfect. Okay.
Okay. Thank you.
No problem.
Nikita, is anyone in the waiting room?
I'll check.
It's basically 1:30 now. Hello, everyone. So thank you all for coming. If I'm looking in different directions, it's because we have more people coming in person, and I think more people need to join. But I feel bad for those that have been waiting for a while. So I'm just going to start now. If you have any questions, just put them in the little chat and hopefully I see them. And we have more people coming. I've just started, so don't worry. So today I'm going to do some colorectal surgery teaching for it's in collaboration with MedEd and Scalpel, and we're going to do a big teaching series. So you can see here, last week we did general surgery, and we're doing opthal next week. Really recommend coming if you're a first and second year. If you're interested in surgery, you might find it really helpful, and also clinical years, of course, please come. And this is every Wednesday in person and online as well. So this is what we're going to be covering today. So we're mainly looking at the presenting complaints, which is the main point of this whole series. I also recognize that this is for all year groups, so I've tried to incorporate everyone in this. So we're going to be going over presenting complaints, looking at differential diagnoses, making sure that we're doing our red flag symptoms, because a lot of the time in history taking, you can fail if you don't include them. Investigations and management, and also when to involve surgery, because we don't have to do surgery every time. And also I've included exam questions at the end and any top tips. So to begin with, I just wanted to do some embryology and anatomy first, just because I think it gives a nice broad understanding. Do that one as well. So we have three different parts to our GI tract in embryology. So we have our foregut, midgut, and hindgut, and they all have different what do you say? They all have different blood supply. So our foregut starts at the distal esophagus all the way down to about halfway to the duodenum. And this is all supplied by our celiac trunk, and that comes off our abdominal aorta. We then have our midgut, which goes from about second half of the duodenum all the way down to about 2/3 of the transverse colon. I might be able to get a laser pointer on here. Yeah. And that's all for the superior mesenteric artery. And then anywhere from the second half of 2/3 from the transverse colon all the way down to the rectum, that's from the inferior mesenteric artery. And that's all of these vessels come off our abdominal aorta. And then this was just a little image that I saw from one of those revision websites, because especially for preclinical years, I remember this coming up a lot, especially knowing the level at which these vessels come off the abdominal aorta, so T12, L1, L3, and then also you then have multiple blood vessels that come off these main ones. And I remember getting certain images, like things like the stomach, even though that's not colorectal, knowing which vessels supply different parts of the organs are really important. And so this is just a basic understanding of the colon. I'm sure everyone knows what this is. So it extends from the cecum all the way to the anal canal. And the main role of the colon is for water absorption. So then it forms your feces, which is solid. And then these are the main parts of the colon. So our ascending, transverse, descending, and sigmoid. We then have our cecum, and then our appendix as well. And our small intestine will attach to the cecum, and you have the ileocecal valve there. So that just gives a broader understanding of the anatomy side. And then these are our main presenting complaints that we're going to go through today. So the ones in red are the main sort of red flag symptoms you want to look for when you're taking a history from a patient, and ones that should be sort of ringing alarm bells. It also depends on multiple other things as well, which I'll go through later. So one of the main common presenting complaints is a change in bowel habit. So anything that's abnormal for the patient, so having diarrhea all of a sudden, constipation, they could have a mixture of both. Rectal bleeding, which can vary from being very minor things like a fissure all the way down to quite severe things, quite sinister things like malignancy. Weight loss, fatigue, these are all common red flag symptoms for possible malignancies as well. Mucus, abdo pain, incontinence, these can all be related to things like IBD. Tenesmus is when you feel as though your rectum hasn't fully emptied, even if you've just gone to the toilet, which is quite commonly seen in things like ulcerative colitis as well, which we'll go through later. Let me just see if anyone else has joined. Okay, that's fine. So I wanted to incorporate things for year 1 and 2 as well. I mean, this applies to everyone, but things like history taking. So I want to start off with rectal bleeding. So I try to incorporate Socrates in everything, even though majority of the time it's only for pain. So S is for sight. So it might sound a bit silly asking a patient, are they sure it's coming from the back passage? But it could be from other places, especially women, from the vagina. For things like periods, you just want to clarify where it's coming from. Then O is onset. So when did they first notice this? So this can be helpful for knowing if it's acute or chronic. C, I changed to color. It's usually character. So we want to know actually what the color of the blood is. So if it's fresh red blood, bright red, then you're thinking something lower down the GI tract. If it's dark red, you're thinking more possible like upper GI. Then also how much is it streaks of blood? If is it like teaspoons amount of blood? R is radiation, so it doesn't really apply in this context, but the way I tried to think of it is sort of location wise. So is it when you wipe and it's on the tissue? Is it in the toilet bowl? Is it mixed in with the stool? So this again can be really helpful for figuring out where actually is the bleeding located. Then A is systems review. So going back to the other side, you don't want to just ask about rectal bleeding, you want to ask about other symptoms. So kind of like a head to toe system that you can do if that helps. And then T, has this happened before? If it has happened before, have you had any treatments for it? How long ago did this happen? And then E is exacerbating factors. So does anything make it worse? Anything make it better? Have you had any trauma in the area? Then S is usually severity, but you can't really ask a patient how severe is the bleeding from a scale of 1 to 10. So I just changed it to smell for anything foul smelling, but it's not really too relevant and you don't really need to worry about it much. So this is the first sort of patient, has painless rectal bleeding and pruritus. So they have itching. So this could be a number of different things. Do any of you guys know what it could be? Yep. So hemorrhoids is like kind of the top differential that you could think of. So when anyone comes with rectal bleeding, especially in like a GP, majority will get a DRE done. And one thing to note with hemorrhoids, you can't really feel them when it comes to internal hemorrhoids. So they probably need to like get a scope to see if they're actually there. It also depends on the patient in terms of age as well and other symptoms they come with, on what further investigations you want to do. So if it's quite a young patient and they've come with painful rectal bleeding, you're probably going to think it's a fissure probably. But if they don't have any other red flag symptoms, no other sort of things that you're concerned about, then they can just treat them medically and then wait until it's healed when you might want to do a DRE, because these patients are not letting you do a DRE exam on them. And then if they have those red flag symptoms like possible altered bowel habit, if you suspect IBD, so if they have those symptoms, then you could possibly do like a colonoscopy, go down the 2-week wait pathway. And then when we think about risk factors, if we start with hemorrhoids, one of the things that can cause hemorrhoids is just sitting on the toilet for too long, so excessive straining as well. Increasing age is also another thing that increase your chances of getting hemorrhoids. Raised intra-abdominal pressure, so pregnancy, ascites, these patients are more likely to get them. And also if you have a history of like chronic constipation, it puts a lot of pressure in those areas. So this is usually where hemorrhoids occur. So we have 2 different types, mainly internal and external. Does anyone know what the arrow is pointing to? If you're at home, you can put it on the chat as well. So that's the dentate line. So it's basically marks the ending of the hindgut. So anything that forms above the dentate line is an internal hemorrhoid. Anything that forms below is an external hemorrhoid. And normally we have normal hemorrhoidal tissue, and that forms like our normal anatomy. And then what can happen is that tissue can become enlarged, it becomes congested, and then that's when patients get symptoms. And usually with internal hemorrhoids, you don't really get pain because there's usually like a lack of sensory innervation to that area. And then these are the common places where you'll find hemorrhoids. So if you imagine looking at a patient, like an anterior view, and then imagine a clock. In an exam, this is where they'll probably say they are in relation to a clock. I'm not really sure why they are in those particular areas. I don't know if that has to do with the blood vessels. And then these are how hemorrhoids are graded. So this is for internal hemorrhoids and pretty much how much they prolapse. So grade 1 is when it doesn't prolapse. Grade 2 is when it prolapses on defecation and it spontaneously goes up itself. Grade 3 is when you manually have to reduce it, and grade 4 is when you can't reduce them at all. And a lot of times hemorrhoids can be treated conservatively, like at your local GP. If they are painful, they can give analgesia, stool softeners, laxatives if someone's really constipated. Also, diet changes are really important as well. So low fiber diet is one of the main causes, and also having a Western diet doesn't really help with that. And also making sure patients are drinking a lot of fluids as well. So these are quite simple things that patients can do. However, there are a few complications that can come with hemorrhoids. So one of them is they can become quite thrombosed, they can be quite purple in color, and they can be quite painful. It can be a medical emergency, but in terms of NICE guidelines, it depends on when a patient presents. So if a patient presents within 72 hours, then you want to think about probably admitting and doing some surgical management. If it's after 72 hours, then it probably can be treated conservatively. With like analgesia, stool softeners and things like that. And also strangulation as well. So it can pretty much cut off the blood supply to the hemorrhoid and the surrounding tissue, which isn't very good. So if conservative management doesn't work, then if it's like a grade 1 or 2 hemorrhoid, then you can do something called rubber band ligation. So this is like an outpatient procedure. It's not really invasive. So it's when you pretty much suck up the hemorrhoid and you put a band over the neck of the hemorrhoid, and it cuts off the blood supply in a very controlled manner. And then the hemorrhoid eventually falls off and shrinks. If that doesn't work, then you could do something called a transanal hemorrhoid dearterialization. Another word for that is hemorrhoidal artery ligation. So it's when they'll insert a Doppler to figure out where this artery is that's supplying the hemorrhoid, and then they'll suture around it to pretty much disrupt the blood flow to the hemorrhoid, and then it will eventually shrink and fall off. It's quite a good procedure because it doesn't require any major surgery. There's no major cuts or anything. So it tends to heal quite quickly compared to other procedures. If it is really severe and nothing else worse, band ligation don't work, then you can do like a hemorrhoidectomy. There's different types. They can get excisional ones where they'll just manually remove it. This is an example of a staple one where they sort of mount the hemorrhoids into the place where they're supposed to be, and they'll staple around it and disrupt the blood flow. And then eventually the hemorrhoids will shrink and fall off. So that's sort of the main things about hemorrhoids. And then this is a patient, I don't know why it looks like that. So there's a patient with painful bright red rectal bleeding when wiping. So when we think about painful bleeding, it's bright red. Sorry, my voice is breaking. We would probably think of anal fissures. So anal fissures are a tear in the mucosal lining. There's not really too many complications with these. It's mainly due to trauma, due to defecation. Sorry. Usually things like constipation, it can cause a lot of damage to the area, and they're split up into acute and chronic. So if it's less than 6 weeks, we're thinking it's more acute. If it's more than 6 weeks, we've had it for, then it's chronic. And they can also be then further categorized into primary and secondary. So primary is when there's no underlying cause. Secondary is when there is some underlying cause. So it could be like an IBD, ulcerative colitis, or Crohn's. So usually they are treated conservatively. There's not really much you need to do. You can give some creams for them, things like Anusol, which are like steroid creams, which can help, which you can get over the counter, analgesia, same dietary requirements, the same as hemorrhoids. There are some patients that might want to go into looking at Botox injections where it relaxes the sphincters and it can help relax them and there's less pressure on them. If all else fails, then one of the things you could do is a lateral sphincterotomy. I think I pronounced that right. So that's where they'll make a small incision into the sphincter muscle and then it can relieve the pressure on the muscles themselves and it can allow better healing. And now if we go to abdo pain, so again, Socrates, so this is a lot easier because Socrates is for pain. So thinking about site, so where actually is this abdo pain? And the reason why this is important is because it's not always GI related. So it's probably worth memorizing this because so you can like just quickly recall it. So if it's more generalized abdominal pain, like very diffused all over the abdomen, really severe, you're probably thinking of like a bowel obstruction. If it's higher up, like a burning pain, it could be acid reflux and also peptic ulcers. If it's really severe pain, if it radiates to the back, you're thinking things like pancreatitis. So it's just important to remember that it's not just a GI condition. And also you can ask the patient to actually point to where it is. And then O is onset. So when did they first notice this pain? So again, this can help if it's acute or chronic. Character, so what does it feel like? So you have loads of different types of pain. You have a burning pain, sharp stabbing pains. Is it cramping? Does it come and go? So like your typical colicky pain, which could be related, more bowel related. Then R, radiation, does it move anywhere? So certain conditions can have pain where it radiates. So it's not GI related, but things like renal colic moves from the back, from loin to groin. Appendicitis moves from the midline to the right iliac fossa. So just asking those can really help to narrow down your differentials. And then associated symptoms. So again, right from the beginning, when we were asking those red flag symptoms, which are really important, we want to ask them, as well as bowel movements, as well as if they've been like ill recently. It could be things like a viral thing. So you want to make sure that you're not just focusing on abdo pain because the other symptoms can tell you a lot. And then time. So is the pain always there? Does it come and go? Does it come at particular times? It could be that certain foods make it worse, like celiac disease with gluten. At night, things like acid reflux can make it worse at night. So that can be really helpful as well. Exacerbating factors, anything make it worse or better? Have they tried any medication? Which is worth asking. And then the scale of 1 to 10, especially in emergencies, it's good to ask from a scale of 1 to 10 because when you give pain relief, they can give you another number. And you can actually see if that pain relief is working or not. And one of the conditions I wanted to just briefly go over, which comes up a lot in exam, it's not really colon related, but it's more small bowel related, is acute mesenteric ischemia, which it's quite an emergency. So sudden severe abdo pain is what they'll come in with. So it's when you'll get an embolism that goes into an artery that supplies the small bowel. So going back to the beginning, the blood vessel that supplies the hindgut is the SMA. And it's usually in patients with AF, so that's something that you might see in an exam for their past medical history. If they've got signs of sepsis and a raised lactate and metabolic acidosis, you'd think about doing a CT angio, which can help diagnose them as well if you have time. And then pretty much the management is surgery, so laparotomy. But if there's signs of peritonitis and sepsis, you want to also treat that as well. And if the surgery is delayed, there is quite bad poor prognosis with these patients, unfortunately. And now we're going over diverticular disease. So with diverticular disease, there's a lot of different words that mean a lot of different things. So diverticulum is when you actually have a pocket that forms in the bowel, which looks like this. And then the plural version of diverticulum is diverticular. So it looks like a hole, but it's not actually penetrating through the whole colon wall. Diverticulosis is just having the presence of diverticular. without any inflammation, so they won't really have symptoms. It can also sometimes be called diverticular disease when a patient is then presenting with symptoms. So it could be like change in bowel habit, slight pain. And then diverticulitis is when it becomes inflamed and infected, and it most commonly affects the sigmoid colon. You can also see it in small bowel, but it's less common. You have Meckel's diverticulum, that's a congenital disorder that affects the small bowel. You can also get them in the esophagus as well, but they're usually like accidental findings and they don't really cause many issues. So this is pretty much how they form. So the top image is sort of the layers of a normal bowel, your colon. And the one that we're interested in is this main sort of circular muscle layer. So we have these arteries that penetrate through, and the parts where they penetrate through are known as sort of like the weak areas. And what can happen is if there's increased pressure in the lumen of the bowel for some reason, then that can cause a lot of pressure in those weak areas. It can cause this circular muscle at the bottom. You can see it's separated, and it then causes the mucosal layer to herniate through. And then that's pretty much how you then form those pockets. It's important to remember that you don't get diverticular in your rectum because you have a longitudinal muscle layer, which then stops the diverticulum from occurring. So that's pretty much how they're formed. And there's multiple different things that can make you more likely to get them. Majority of people, when they're old, they'll most likely have them, but a lot of people, it won't cause them issues. So increasing age is one of them. Again, low fiber diet, obesity, the Western diet, use of NSAIDs can make you more likely to get them. And it's usually diagnosed with a colonoscopy. So this is what you would probably see. And then also you can do a CT scan as well, but colonoscopies are usually just more efficient. And then management, again, just dietary changes, and also laxatives if patients have things like constipation as well. And then surgery may be required, but it really depends on the symptoms, which I'll go over in a second. This is what a CT scan of diverticular disease looks like. So all the arrows are pointing at the diverticular. This is obviously a patient with quite severe diverticular disease. So then if a patient then all of a sudden gets quite painful tenderness in the left iliac fossa, they have a change in bowel habit, nausea and vomiting, which is more of a late sign, and then rectal bleeding, we're then thinking of possible diverticulitis. So this is pretty much the management. So you want to make sure that you're giving antibiotics if it is signs of infection, analgesia, because they're going to be in quite a lot of pain, but you want to avoid NSAIDs. Liquid diet, and also you want to follow up 2 days to actually just review their symptoms. However, some patients will need hospital admission, and that's if they have signs of an acute abdomen. So that's when they have that severe sudden onset abdo pain, and also if there's possible signs of sepsis. So then that's sort of the treatment that you would want to, investigations and management you want to do. So you want to make them nil by mouth. You don't want any fluids or anything going down there. Antibiotics, yeah, you can give fluids, CT scan, and then also surgery. So surgery depends on if the severity of it, if it's like a continuous thing and it just keeps on coming, it might be worth possibly removing the sigmoid colon if it does occur in that area. And then I wanted to just go over a bit of hernias, because hernias are very common. That's sort of the surgical definition of a hernia, so protrusion of a viscus into an abnormal space. But the basic understanding of a hernia is that it's an organ or a piece of tissue that passes through a hole that just ends up where it's not supposed to be. And there's many causes. The main two are increase in intra-abdominal pressure and weakened tissue. So you can get it in a lot of rest patients. Again, patients who are pregnant and have ascites, if they have chronic constipation, and then if they have any sort of congenital defects, colonial disorders, any trauma to the area, and also age as well is a big factor. So this is just what a normal abdominal hernia looks like. So you can see it protruding outwards. And then here's the neck of the hernia. And then a lot of issues can occur with them, a lot of complications. They become strangulated, where it cuts off the blood supply, which you can see here. So there's different types that you can get. So and different terminologies. So reducible, so it's kind of the same thing with hemorrhoids, if you can push it back in. Incarcerated is when it gets stuck and then you won't be able to push it back in. Obstructed is when it becomes quite compressed, and then that can also lead to an obstruction. So something could be externally obstructing the bowel. And then strangulated is when it completely cuts off the blood supply, and then you can get infarction and necrosis. And this will definitely need surgery because you can become quite septic. And then you also want to worry about possible perforation as well if there's a lot of pressure. So this is something that you could see. So it's quite necrosed. So this would be something that's quite strangulated and it would need like immediate surgery. And then that kind of follows then on to bowel obstructions, because hernias can cause obstructions. So an obstruction is sort of something that's defined as just absolute constipation. They won't even pass gas. They could get quite a distended abdomen, and it could be quite painful. Those are the three sort of main causes of bowel obstruction. There's quite a few others as well. So something malignant can be blocking the colon, a volvulus, which we'll go through in a second, and then again, diverticular disease. Things like nausea and vomiting, they're quite late signs of a large bowel obstruction. And then this is what you would see on an X-ray. So one thing that I learned to sort of help is that the small bowel is about 3 centimeters, the colon's about 6 centimeters, and then the cecum's about 9 centimeters. So anything over that, you're thinking possible obstruction. And you can tell it's the large bowel because you have these lines going across the bowel. So those would be your posture, which you don't really get in your small bowel. So that can help to differentiate. You can also do a CT scan as well, but that's an X-ray of them. And if you have someone with a large bowel obstruction, you want to make them nil by mouth, because if nothing's going past there anyway, what's the point? And then IV fluids, an NG tube, and then also IV antibiotics. You want to think about antibiotics if there's like perforation, ischemia, and then that's when you want to think about possible surgery. However, if a patient doesn't have any signs of peritonitis and sepsis, then you can possibly manage them conservatively if it's quite a slow onset, and you could probably let it pass naturally. You can give laxatives as well, because it could be also like fecal matter that could be blocking the bowel. So yeah, if there's signs of peritonitis, then you want to think about doing an emergency surgery. So those are the different types of surgeries that you can do. So it really depends on which part of the bowel is obstructed. So segmental is removing sections of the bowel, then joining them together, forming an anastomosis. Hartmann's procedure I'll go through in a second. Subtotal or total colectomy would be just removing the whole colon. So that could be seen in like malignancies or toxic megacolon, which you can see in ulcerative colitis. And then you also might want to give stomas as well if forming an anastomosis isn't very safe. And this is what an anastomosis would look like. So it's pretty much just joining the two ends together. There can be a lot of complications with these. There can be a lot of infections. So you want to make sure there's careful monitoring of these, of the patients as well. And then in terms of a volvulus, if I just go to the next one. So this is what it will look like on an X-ray. So this is a common sign for a sigmoid volvulus, because it has that classic coffee bean shape that you'll probably see in an exam maybe. So volvulus is when the bowel twists up upon itself, and there's a number of different things that can cause them. One of them is constipation. So what can happen is the sigmoid colon can get flowed with feces. It can then sink the sigmoid colon down and then pulls on the mesentery, and it can twist on itself. One of the causes actually of a volvulus in terms of diet is actually a high fiber diet. And also things like excessive use of laxatives as well. You can also get them in the cecum, but they're usually less common, and they're more common in younger people. So then in terms of management, the initial one's the same as a bowel obstruction, so making them nil by mouth and YouTube and IV fluids. You can do conservative management where you decompress it endoscopically, or you can put a tube and decompress the bowel and just pretty much leave it there, and that should help. But if not, then again, surgery like a laparotomy, Hartmann's, or you can do a hemicolectomy as well. So again, it depends on the patient, which I'll go through later. And then in terms of stomas, these are the main two groups of stomas, so an ileostomy and a colostomy. So usually your ileostomies are on your right, colostomies are on the left. And in terms of the differences and what they look like, so this is what a typical ileostomy would look like. So it's more sprouted out, and that's because the stuff that's coming out of it is more fluid. It can cause a lot of irritation around the skin, so you don't want that to be in contact with the skin. And then a colostomy is more flatter because it's more solids that it won't really impact the skin too much. And then also this is spoken about with patients on where the stoma bag will be beforehand, because a lot of patients might have issues with them. And if they have if someone properly speaks to them about the stoma, then they're more likely to adhere with it, and it can prevent things like leaks and stuff. And then you also have end colostomies and end ileostomies. So the image on the left is like a typical Hartmann's procedure. So it's removing part of the sigmoid, and then this part where the sigmoid has been removed would be where your end stoma would be. The rectum would be left in place, and then the anus can be sewn up. The thing about this procedure is that it can be reversible, so you can just join those two ends together to form an anastomosis. With an ileostomy, those are given to patients where you'll have to remove the whole colon, and then you'll form an end ileostomy. It really depends on the patient, because you then can form something called a J pouch. And that's when you fold the part of the ileum together and it kind of forms a little rectum. And some patients might prefer that. However, it does mean that they'll then need another surgery. So it really depends on patients' preference and if they're okay with staying with a stoma, or there can be things done to help. And then you do have loop colostomies and loop ileostomies. This was a really helpful image I saw when I used to revise for colorectal. So loop colostomies and loop ileostomies, they're temporary stomas, and they're used mainly for patients with things like anastomosis. So anything that you don't want going through the distal portion. So if a patient's had an anastomosis, you then don't want them to have any feces going past it, because you want it to allow it to heal. So what happens is you have two ends, you have a proximal and a distal. So your proximal would be the productive side, so that's where your stool would come out, and then the distal is more flat on the surface of the skin, and then nothing goes past there. And then eventually, when the surgery, say, is healed, they can then join those loops back together, and then it's only temporary. And then this is just what they look like, the difference between an end and a loop. So you can see, obviously, there's two holes there. And then, as like with every surgery, there's many complications that can come to it. So when a patient has just had their stoma bag, like with a lot of surgeries, they can get bleeding, infection. The stoma can actually have too much coming out of it, so then the patient can get dehydrated. The stomas can pull back and it can become retracted. And then late complications are things like possible prolapses, stenosis or strictures forming around the area, and also psychological issues, because having a stoma bag is quite a big deal for I think many people, and being able to change a stoma bag in public and things like that, you really want to take into account when speaking to a patient when they might possibly have to have one. And then going on to other conditions like ulcerative colitis. So ulcerative colitis is one of your IBDs, as well as Crohn's disease. And one of the things you'll see in an exam is they'll get like bloody diarrhea, have increased urgency, tenesmus, and abdo pain. So ulcerative colitis mainly affects the rectum and then goes upwards. So you can see it's quite continuous. Whereas with Crohn's, you'll get those typical skip lesions. And with ulcerative colitis, it doesn't go past the ileocecal valve, so it only affects the colon. And it usually affects younger people. So it can affect as young as people like 15 to 25. And then there's usually a gap. And then it affects older people around 55 to 65. And then usually in terms of investigations, things like colonoscopies, where you can actually see the inflammation. And in terms of investigations as well, you want to do a lot of bloods. So your main typical ones like FBC for any anemia, if there's any bleeding, CRP for any inflammation, U's&E's, LFTs, TFTs, and then anti-TTG to sort of rule out celiac disease because they can present in similar ways in terms of abdo pain. Fecal calprotectin is usually given to a lot of patients if they have any abdo pain or any bleeding. So calprotectin is produced during inflammation, and it can be a sign of IBD. It can also be helpful to distinguish between IBD and IBS. So IBS is more a diagnosis of exclusion. And then again, colonoscopy can be used, and then other images like an ultrasound. And this can be done for complications which can arise with ulcerative colitis. And this is a typical sort of X-ray that you can see. So the one on the right is someone that's taken a barium enema, so it's a lot clearer to see on there. So you can see there's a lack of Hornstra here. So it's that typical lead pipe sort of presentation, and that also comes up a lot in exams as well. Things like the progress tests. And then there's a lot of medical management, which I won't really go into, but if the medical management doesn't work, then patients might potentially need surgery. So again, it depends on how severe the ulcerative colitis is. You might want to remove parts of the colon and form possible loop ileostomies and then form an anastomosis. You might want to remove part of the rectum as well, or you might want to remove everything. So removing the rectum, the entire colon, and then they're left with an ileostomy, which would be permanent. And then with Crohn's disease, again, it depends on the patient, but Crohn's usually affects your ileum. It affects anywhere from the anus to the mouth to the anus. And usually it's the small bowel that's affected. So you'll do small segmental resections of the bowel. So then you'll form multiple like anastomosis. But majority of patients with Crohn's actually end up getting some form of surgery done. So that's sort of like the IBDs. We move on to things like cancers. So these are like the main red flag symptoms. They most likely won't present with all of them, but change in bowel habit, rectal bleeding, unexplained weight loss is a big one, and then fatigue. You're thinking of possible malignancy maybe. So a test that you can do, which forms part of the bowel screening process, is a FIT test. So anyone ages between 60 and 74, I believe, are sent a center FIT test every 2 years to see if there's possible signs of malignancy. If it's positive, then that's when you want to go down the route of possible 2-week wait pathway. If it's negative, then you want a safety net. Make sure that they do it again in the next 2 years. And if there is ongoing concern, if there's a big mass somewhere, then you might want to still consider referring anyways, because like every other test, they're not always 100% accurate. And then these are just the typical pros and cons of screening. So we can detect cancers quite quickly and early. However, it does mean once patients get tested, they might think they'll never get the cancer because they're negative this time. However, it's important to remember that cancers can form pretty much at any age. And then in terms of your colorectal cancers, these are the common sites that they form. So it's mainly in the rectum and the sigmoid, where they are the most common, followed by ascending and cecum, and then transverse, and then descending is usually the least common. And you have your sort of 3 main types. You have your sporadic, which is ones where you don't really have any sort of genetic factors that will give you cancer. And then you have HMPCC, which is also known as Lynch syndrome, and then FAP as well. So this is an example of what FAP can look like. So you have multiple polyps that form in the colon. And pretty much one of these is most likely going to, pretty much 100% is going to give you cancer. So as a preservative treatment, you would want to just remove the whole colon, and then they'll be left with a stoma. And then, like I said earlier, it really depends on the site of not only the cancer, also where inflammation is, just where it is within the colon. So a right hemicolectomy would be the whole cecum, ascending colon and proximal transverse colon. Left hemicolectomy would be anything on the left, so the distal, transverse, and descending. A high anterior resection is removing the sigmoid. colon, but it can also be called a sigmoid colectomy. You have your low anterior resections, which involves removing the sigmoid and the upper rectum, but then it spares the lower rectum and the anus. So that's how you can get your reversible stomas. And then we have, you probably wonder what TME means. TME means total mesorectal excision. So it's like removing the mesentery around if it's been spread. And then your APR, so abdominoperineal resection, so that's removing the rectum and the anus. So then the patient's left with a permanent colostomy. And it also might include the sigmoid, but it depends on the patient. So these were just some exam questions that I found. So you can feel free to answer them and put your answer in the group chat, well, in the chat on Zoom. So this is a 65-year-old man who has come to his GP with blood in his stools. Since a few weeks, he's noticed red blood when passing the stool. But 4 days ago, he's now got pain when passing movements, and he feels a mass around his back passage. On examination, you visualize a purple mass in the perianal area. A DRE confirms a tender lump at the 7 o'clock position. So what's the most appropriate management? A, B, C, D, or E? You could put it in the chat if you're online. You guys can shout it out. Okay, we have some people in the chat. It's not gonna know. Okay, so people have put in the chat. Oh, it's B. So we want to give analgesia. Lost my mouse, one sec. Analgesia, stool softeners, and an ice pack. So like I said, it really depends on the NICE guidelines in terms of when they presented. So this patient presented 4 days ago. So you'd want to do conservative management for these patients. And then I think it's the next one. This is the last question. 72-year-old male has been diagnosed with a rectal carcinoma. He's due to undergo a lower anterior resection, and the aim of the resection is to restore intestinal continuity. What's the most appropriate type of stoma? A, B, C, or D? Let me see if anyone's put anything. Oh, I know the answer. Is it C? So let me check. Yeah, people have put C. So it's a loop. So this person wants to restore their intestinal continuity. So you'd think of doing a loop. So a lower anterior resection, like I said, it's removing the sigmoid and the upper rectum, but you've left the lower rectum and the anus. So it diverts the bowel contents away from the distal anastomosis. And it's often seen in rectal cancers that they'll mainly do a loop ileostomy. And then these are just my main tips, mainly for like preclinical years. So don't neglect anatomy because I think it's really important. And Sam Webster was a person I saw on YouTube, which really helped. He uses those plastic models that you see in your CCAs that will come up in like your DR stations. And then Ninja Nerd, you either love him or hate him. I really liked him. He does waffle a lot, so you need to know when to skip parts of the stuff he says. And then Anki for flashcards. There's loads of like tutorials on YouTube how to start them. Then also just get familiar with your history taking and also practicing to present your histories, because I think a lot of things at med school, they don't actually teach you properly how to present to patient until you're in like the end of second year when you actually need to know how to do it. And then for year 3, just get upstairs and pharmacy tasks done early, especially pharmacy tasks, like everyone neglects them. Get bloods done as much as possible because I wish I did that more often. Then pass med for like exams, questions, 0 to finals for conditions. And then Geeky Medics is really good for CCAs because they have a lot of CCA stations, but you do have to pay for it. And then that is the end. If you could scan the QR code, guys, and then you could fill out a little form, which is like feedback. But yeah. If you have any questions in the chat, feel free to ask any. No problem.
Why do you have to do ileostomies for anterior resections?
For which one?
Anterior resections is my question. Why do you have to do ileostomies?
Because for this patient, they wanted to install to improve their intestinal continuity.
Why can't you do ileostomies?
Oh, that's a good question. You know the answer, you're trying to trick me, that's why.
It's easier to revert.
Compared to a colostomy. Cool. Okay, thank you guys. I think they've all left, possibly.
Loop ileostomy is easier to revert. There's more blood flow, less tension.
Thank you guys.